again, thanks, and we had a refreshment, and I hope that in the next 1 hour and a half or less before lunch I can give some more, let's say, experience to share, but I love questions. Please, let's make questions after or during, even during the presentation, of course, because question can be in Serbian and there will be translation without any problem. So please make me questions so you interrupt me whenever you want. So now we speak about something new. Well, not completely new, but I told myself I go to Serbia and I want to share what's most innovative I'm doing on my patients, just to share this experience after the publication a few months ago, nearly 1 year ago, of this experience. So, catheter, foam sclerotherapy, and compression. Of course, we will discuss about compression. Oh, I need the sorry, I was going ahead. Well, I have no specific, let's say, in commercial interest. Okay, we know that foam sclerotherapy is good. For example, ultrasound-guided foam sclerotherapy, we saw it. For tributaries, we saw it. But, since the very beginning, when we published this article in Phlebology 2000, probably, or 2002, I don't remember, we highlighted that anyway there is some recurrence. You see the C result at 6 months, and recanalization was a little bit more possible when treating larger veins. If you look at Bradbury experience, for example, you see that after, let's say, 1 year, you have something like 82.5% occlusion rate after 1 year. That's Bradbury. And this is another study from the same group where you see that about 15% of the limbs require retreatment by 5 years. That's not recanalization rate. That's the British patients who require retreatment. So probably some 30–40% recanalization after 5 years, something like that, which does not mean anyway symptoms, anyway signs, and so on and so on. If you look at this study and other similar studies, when they compare foam, radiofrequency, laser, surgery, objectively foam has a slightly lower occlusion rate. So as a matter of fact, in terms of quality of life, of symptoms, foam can be very similar to the other treatments. On the contrary, if we talk about recanalization, especially in larger veins, foam is suffering a little bit when we talk about traditional ultrasound-guided foam sclerotherapy. Have been working, I work and have been working in Ecuador and Nicaragua for charity mission, and when we go there, we have big varices, big diameters. You see here 14 millimeter, not meter, that's too much, 14 millimeter stem, so it means very large vein. In a case like this, it was 14 millimeter here, and the junction was around 20 millimeter. So I was obliged to use, let's say, 24 milliliter of foam, 3% STS 12 milliliter for the junction and the stem, and 1% STS fibrovein 12 milliliter foam for the tributary. That's one-shot treatment in Ecuador or in Nicaragua. But again, this is a compulsory strategy and methodology because we have large veins, and again, this is not what I love to do in current practice. That's why in 2009 I published something about possible innovations to improve safety and especially efficacy of foam sclerotherapy. I started to talk about catheter, I started to talk about tumescence, and I started to talk about irrigation. Why? Why should we use such complications, let's say, to improve the results. Let's try to understand step by step the interest, the rationale. There are different reasons: biochemistry, mechanics, efficacy, safety, costs, and at the end of the day, what I wanted to do is to mimic what we do with laser, radiofrequency, and glue. You just replace thermal energy with chemical, let's say, power. Okay? Let's go step by step. In the same year, in the same publication, Phlebology, Kurosh-Parsi, while I was talking about catheter irrigation tumescence, published this elegant drawing where you see the vein and the catheter in, and then it depicts the tumescence around the vein, and finally the vein filled with foam thanks to the catheter. So together, Kurosh-Parsi was publishing this, and I was publishing my own experience. Why should we use catheter, tumescence, for example, irrigation? Well, we know that the higher the vein diameter, the higher the recanalization rate. This is a fact. 10 millimeter veins have a lower outcome, a lower occlusion rate. So the higher the blood flow, the higher the recanalization rate. Hence, blood is our main enemy. I don't know how is blood in Serbian. Krev. Krev is our, just like Polish, like Russian, so it's easy for me. Krev is our enemy. That's true, absolutely true. We started with these results where larger veins had worse outcomes since the very beginning. Similar outcome for Philip Colledge-Smith, for Ken Myers, similar worse outcomes for larger diameters. Here you see Ken Myers, who got worse results for saphenous veins in comparison to tributaries. And veins greater than 6 millimeter diameter got worse results compared to smaller veins. So caliber is an issue. And Kurosh-Parsi started to publish a lot of studies which are so important. These are the three most important conclusions from his studies. I don't want to present all the data because that would be complicated. Anyway, proteins, especially albumins, impact foam sclerosant or liquid sclerosant and inhibit the chemical power. Then, even more, detergent sclerosant are deactivated and consumed by blood cells, especially red blood cells, which are much more than white blood cells. So, at the end of the day, blood denaturate foam. Blood inhibit the chemical power of foam. And then in another study, it demonstrated that the chemical action of foam in great saphenous vein is inversely proportional to the distance from the entrance point. So to be clear, if you put your foam at the distal part of your thigh, then at the level of the junction or the upper part of the great saphenous vein, it will work very, very little because of blood along the pathway. This has been demonstrated, full stop. Mike Watkins, our common friends, Mike, also, but you presented this, demonstrated that half milliliter of blood, which is nothing, let's say half milliliter of blood, deactivate 1 milliliter of 3% STS. So blood, Krev is our enemy. Then with Lorenzo Tessari, we made a couple of studies, which I present here. They were published in Veins and Lymphatics. It's a bit complicated. I tried to make it simple. We injected veins around the knee, and then during crossectomy, he retrieved blood from the common femoral vein. Okay? So blood from the common femoral vein after, immediately after, 2 minutes after, 4 minutes after, and so on, after foam sclerosant injection in the distal thigh proximal part of the leg. Blood from the brachial vein and from the femoral vein. If you look at the blue and the red, these are the curves of STS in the, let's say, blood in the brachial vein, okay, and in the femoral vein. And so you have an increase of STS because you put a drug and the drug goes into the blood. Okay. If you remove the proteins in the femoral vein blood, this is the curve. How much free STS is available? 0. Free. Where is the STS? Bound to proteins. So in the common femoral vein, there was no free STS, no active STS, no active fibrovein in the common femoral vein. What does it mean? It means that from the knee area to the groin, the foam was neutralized by the proteins. Then we wanted to know what happens in a shorter time. So we started with electrophoresis, capillary electrophoresis, and agarose gel electrophoresis to understand what happens after a few seconds. And basically, after 8 seconds, the profile is exactly the same with or without STS. So it means STS is incorporated with the proteins. So to make it short, when you put your foam into a vein which is filled with blood, after probably 8 seconds, that foam is no longer active. But that's due to blood. So probably it is active in the point where it doesn't touch blood, but in a distance it starts to be inactivated. Again, CREF is our enemy. Then we know that sides, the larger the vein, the higher the blood amount. But never forget about the tributaries, never forget about the perforators. So not only the stagnated blood, but also the inflowing blood is a problem. That's why tumescence. Everybody knows tumescence for laser and radiofrequency because it's usually used by Professor Popovich normally and so on and so on. What does tumescence do? Increases the transmural pressure, so decreases the vein diameter. The tumescence reduces also all the diameters, size of tributaries, perforators, and so on and so on. So we also decrease inflow, not only the size, but also the inflow. So we may have, we have lower blood amount for a prolonged time. The lower the blood, the lower the thrombus. Richard mentioned sclerothrombus, this wonderful word from George Fagan. It's not thrombus, it's not sclerus, it's sclerothrombus, what we create. How much blood is in the vein? 10. We have a 10 thrombus. 1, we have a 1 thrombus. The residual part is sclerus. So the lower the blood, the lower the thrombus. Thrombosis recanalizes. Sclerosis does not recanalize. That's why reducing blood, we reduce the thrombotic component, we increase the fibrotic component in the sclerothrombus. Okay, Nick Morrison. Nick Morrison is the current UIP president, the world president from USA. He's a great, great friend of mine, a very nice guy. He would love to be here, I tell you, because he loves to come to Serbia. He was in Russia with me. He was in Poland. Okay, the Eastern Europe he likes, and we were together many times. Okay, long time ago when I started my tumescence, I was not very good in tumescence because that was my learning curve. So I told Nick, I want to use tumescence for foam with catheter because I do think it helps, but I cannot perform it properly. So I was not good as you, Professor Popovich, probably it was 2010. And so Nick told me, okay, I teach you how to make it, give me a big vein and I will show you. So I prepared for him in Rimini, we were in Rimini, a very large vein, 24 millimeter in lying position, 38 millimeter in standing position, like this. So it was a very, very large vein, Godzilla again, okay? That's a saphenous vein. And he told me, oh, Attilio, that's quite large, 38 millimeter. Okay, and after tumescence, that's the result. The same vein, the same patient. So I was shocked, and everybody would tell that it's much easier to get the good outcome here than here. Here there is nearly no blood, and here it's a lot of blood. That's tumescence. That's it. We don't need to tell anything more. That's why we need a catheter or a cannula. We are discussing with the STD to get some more advancements about that, because catheter could be a good option, especially for larger veins and tumescence. So we wanted to test, does tumescence work? We published this study. We were at the European Venous Forum and so on. So 3 different groups. This is not a randomized controlled trial, but it is a comparative study. 3 different groups, 17 patients without tumescence, 17 patients with tumescence under visual control, 17 patients with ultrasound-guided tumescence. This is the catheter with a surgical access or transcutaneous access, and then we perform tumescence. Well, one group without, one group only visual tumescence, and the other group under duplex guidance. As you can see, in this case, differently from laser, tumescence is only in the saphenous compartment. We don't need to protect the skin because there is no thermal energy. It's just foam. So we want to squeeze completely, and the vein is attached to the catheter. So it means the vein is 1 millimeter residual caliber because it's completely attached, squeezed to the catheter. The 3 groups had a similar follow-up duration. These are the clinical results. We performed phlebectomy for the tributaries and catheter for the saphenous vein. After 14 months, there were no recurrences in the ultrasound-guided tumescence group and 6% recurrence in the 2 other groups. But more importantly, at duplex assessment, this is the occlusion rate. As you can see, the blue occlusion rate is better for the tumescence group, and it was statistically significant. And when the vein is patent, there is a group of veins which have an antegrade flow. We can discuss about it if you like, because I love to explain what it means, but that's antegrade flow in a patent vein, which is interesting after sclerotherapy, because it's a normal vein with antegrade flow, because of very small caliber. And when the veins are patent, you see the group after ultrasound-guided tumescence as a very low caliber, less than 1 millimeter. The other patent veins had an average caliber which was higher. So at the end of the day, if you reduce the blood, even if it recanalizes, it's a much smaller because of fibrosis, which is higher. So tumescence works. Why should we use irrigation? Well, I would say because I have I had the long experience with catheter, with tumescence, and as I try to be perfect, let's say, in my procedures, which is not easy to be perfect, I would say it's not possible to be perfect, I checked all my veins during the I checked all my patients during the starting learning curve. Notwithstanding tumescence, there is the residual venular pressure which gives some blood into the vein, notwithstanding the tumescence. So I checked, and there was some little blood in the saphenous vein after tumescence. Okay? How to clean? With saline solution, irrigation into the vein prior to foam entrance. So while I was performing tumescence, my nurse was clearing the vein, as I will show in the video. So I can clear all the blood from the saphenous vein, from catheter, and from the tube, external tube with the entrance kit. This means that I create a kind of desert inside the vein, nearly no more blood. And that helps to increase probably the magnitude of sclerosant contact with the vein wall. Ken Myers presented, here you can see a study, published a study, where simple irrigation with liquid sclerotherapy got the same results he got with foam sclerotherapy. So anyway, irrigation seems to be very interesting. How can you irrigate? You will see live demo on table. I mean, just to show you the catheter, you will see a video. But anyway, when you put the catheter, and if you do it transcutaneously, you have an introductory kit and you have an external tube. So basically, if you give saline solution from here, the introductory kit ends here, so the distal part of the vein is washed by this saline. This is connected to the tip of the catheter, which is close to the junction. So basically, from here and from here, you clear all the vein from blood thanks to saline solution. And then I started to check again, and I saw no blood. Oh, I'm happy now because I see no blood. And I started to perform. So this is tumescence, this is the catheter in, and this is the final results. A tiny, tiny white hair, let's say, okay? 1 millimeter white hair, which persists like this for minimum 20-30 minutes. This is what we saw during our duplex examination. More than this, thanks to tumescence, thanks to irrigation, even the tributary, which was entering the safena magna, was obliterated. So the erasure effect, the inflow negative effect, was abolished. That's why abolition of stagnating blood and inflowing blood was so important in our idea, in our experience. So, is it effective? Well, I demonstrated that tumescence is effective. Then I published an article, I will show you in a second. Then I published an article about our experience. How do we work normally? We perform catheter foam sclerotherapy for safena magna, or for safena accessoria anterioris, or for safena parva, and we combine catheter foam sclerotherapy with tumescence prior to foam entrance, with irrigation prior to foam entrance. But well, for tributaries, for varices, we prefer phlebectomy. We can discuss. You can use foam sclerotherapy, and they would love. I prefer phlebectomy, but foam sclerotherapy can be used. We know it. It's a matter of organization. If you use catheter, you can perform just maybe 2-3 phlebectomy here, and then the rest will be for foam. It's up to you. I don't want to stress this point. But catheter, foam sclerotherapy, plus ultrasound-guided perisaphenous tumescence and saphenous irrigation. Okay? Okay, let's go ahead for a second. And this is the paper that we published recently, a few months ago. I think it's November, 1 year ago, in the European Journal of Vascular and Endovascular Surgery. So in this paper, we presented our, let's say, not preliminary, but mid results, because the latest results are even better than these ones. But okay, this is our experience. We treated 88 limbs, 82 patients, with primary varicose veins and safena magna incompetence and terminal valve incompetence. Why do I tell you this? Because our average diameter was nearly 8 millimeters. You read the publications 5. Both Philip Courage-Smith and radiofrequency and laser 5.5. We decided, because we are masochistic, we decided to treat 8 millimeter vein. That's another story. That's a lion, not Godzilla, but that's a lion. So to treat lions, you need radiofrequency, you need laser, because foam could be suffering. We decided to treat only terminal valve incompetence, and so a little bit larger diameter. We use 7 milliliter of foam during the procedure for the saphenous vein. Everything was done in local anesthesia. It was cannulated with access kit and the 4 French catheter, which I will show later, with closed tip side holes. That helps not to spread too much foam from the distal part of the catheter. We perform ultrasound-guided perisaphenous tumescence infiltration. We use buffer mepivacaine with adrenaline, something like the Klein solution, which everybody uses probably for laser and radiofrequency. And my nurse was somehow flushing the vein during tumescence and especially just before foam entrance to clear completely the vein before I enter my foam. Foam was created through 3% fibrovein and CO2 plus O2, but okay, you can use air, through Tessari method, and a 4 French long catheter was used. This is the kit, I will show you later. And then, this is true, this is not advertisement for Medi. It's not advertisement for Medi, this is true. We put Struva 35 in all patients. In this case, only Struva 35. You see during the procedure how to put Struva and some additional pads to increase the pressure over the operated area. The patient stands up basically in 10 minutes and goes home in 30 to 60 minutes. And this is something I will present later, but you probably got the paper. I think they got the paper.
Yes.
Yeah, you got the paper. Okay, I will present about that. So let's have a look at the follow-up. We checked the patient 1, 6, 12, and 36 months after the operation. If you look at the procedure-related symptoms, they are very, very little. So no special pain, because it's not thermal energy. That's why it's better than laser in this comparison, of course. And laser has other advantages, of course. Anyway, procedure-related symptoms, very low. Improvement, generally speaking, of heaviness, pain, and paresthesia was achieved after 40 days. Let's go to the most important issues, not only symptoms, but varices. Thanks to phlebectomy, thanks to catheter foam sclerotherapy, the clinical recurrence at 36 months is 5%. Now we move to the referee of every single treatment. Duplex is the referee. This is the duplex. Again, at 3 years, we had 89%, 0.4% of occlusion rate. We had a 3.5% recanalization with reflux, and we had 7% recanalization with antegrade flow. If we sum up these two positive outcomes, occlusion with antegrade flow, we get 96.5%. So if I am a liar, okay, I am a liar. But if I am not a liar, well, I think no one can get these results with foam sclerotherapy traditional. It's impossible to get these results with traditional foam sclerotherapy. It's possible with catheter, tumescence, and irrigation, which is a complication, I know, but when you fight against lions or Godzilla, and when you fight against laser and against radiofrequency, you should get strength. You should use the same weapons, because laser and radiofrequency use tumescence. Why shouldn't I use the same weapons? And then I get the same results. So it's something which I consider interesting. This is the Kaplan-Meier curve. And again, what we see is the disappearance of the vein, which is not so easy again with traditional foam sclerotherapy. That's before and that's after. The world is starting to use catheter in India, in Egypt, in Poland, in Russia, not only because I was there, but because they like the treatment and they start to compare with radiofrequency. You see very similar results, catheter foam sclerotherapy with radiofrequency, for example. Then the Egyptians, they came to Italy to see me at work. They wanted to learn from Egypt. And they liked the procedure so much, and they published it before me, even before me. I was shocked. They published it before me about the technique, catheter foam sclerotherapy with tumescence, and these are the results that they achieved. They published it in September, I published it in November. Okay. These are friends from Egypt who learned the technique and they liked so much because it works and it is very cheap at the end of the day. Is it safe? Well, this is my only complication I got. One, thrombophlebitis, one varicophlebitis, superficial phlebitis. Well, I operated nearly 1,000, probably 500 patients. So I got 5 DVT in catheter foam sclerotherapy, not in this clinical series. 5 DVT, 3 gastrocnemius, 1 popliteal, sorry, 1 femoral-popliteal, 1 popliteal, 2 gastrocnemius, and 1 peroneal. This is my DVT rate, okay? But 4 patients out of 5 had thrombophilia. They didn't know, and they got thrombosis. Okay, this is the complication rate from the Egyptians, for example. Now we talk about costs, for example, and office settings. Here I am in Brazil performing the procedure on a stage, let's say, which is strange. That means it's not such a big issue to perform catheter foam sclerotherapy. This is a one kit. And if we talk about costs, I don't know the situation in Serbia, but Italians are poor. As we are poor, we want to spare money. When we go to a clinic, at least this is what happens in Italy, and you tell, well, I would like to enter here and to operate. Okay, how much does your operation cost? 500 euro. No, thank you, bye-bye. If you tell it costs 60, 70 euros, please come in and work. This is the situation in Italy, because they want to spare money. And for varicose veins, in Britain, they are even better, because they say C2, no treatment. Is it like that? C2, no treatment in England. You must be maybe C3 or 4.
Getting towards C5, 6 now.
Wow, the British are tough. Well, in Italy that's not possible. You have to treat C2 as well, but they give you 1,000 euro. That's it. You do what you like, even 800 euros. And in Italy, 800 euro, if you spend, let's say, 250 for laser, and then anesthesiology, and then nurse, and then this, and then that, and then surgeon, any hospital, any clinic tells no thanks, no chance to operate for 500 euro costs, let's say. That's why it costs much less. And if we talk about glue, glue is around, if I recall well, 900, 1,000 euros. Only the glue. No chance it spreads in Italy. No chance. I don't know in Serbia if you are richer, but in Italy we have no chance. Then there was one lady whom I like so much, Birgit Kalle, who wanted to destroy, to kill my child, tumescence. And if someone kills a child, the father reacts. Okay, I am the father of tumescence in foam sclerotherapy, and I had to react. And I wrote a letter to the European Journal of Vascular and Vascular Surgery to criticize this murderer. Okay, why? They published an article where they wrote tumescence doesn't work. Wow, they want to kill my child. Okay, so if you look at the results, in fact, the tumescence group, the black one, seems to be a little bit better, not statistically significant. Okay, that's the same in the Kaplan-Meier curve. But then, reading the article, I found so many critical issues, and I put everything in the letter, or nearly everything in the letter, and they published the letter. And Birgit, who is my friend, told, okay, I acknowledge that there were some problems. Okay, so let's have a look. If you look at the article, they put tumescence everywhere, not strictly in the saphenous compartment. So it was not perfectly compressing the vein, maybe, because you see the pictures and tumescence is everywhere, not in the saphenous compartment. They used no adrenaline. It was not permitted by the law. Come on. If you use adrenaline and saline solution and anesthetic, that's tumescence. If you use saline solution, that's not tumescence. You cannot say tumescence doesn't work. You can say saline solution doesn't work. So it's a, it's a kind of wrong, let's say only wrong, tricky concept. So that's not good. Then they treated vein, it's written, of 6.5 millimeter in supine position at the junction. So in supine position, the vein was about 4 millimeter because of the conversion factor between the junction and the trunk. 4 millimeter in supine could be around 5.5 in standing. So they were treating cats. When you treat cats, you don't need tumescence probably, or well, you can use tumescence, but it's not necessarily getting better results than without tumescence. So it was not fair. Let's come to the original sin of this study. 20% of the patients in the non-tumescence group were lost to the follow-up. And the 8% in the tumescence group were lost to the follow-up. Tell me who can publish an article with 20% dropout rate? It's a nonsense. You will know nothing of these guys. So this article was cancelled, and my child is still alive. And you see Turkish, here Turkish are using catheter, Germans, Swedish, English, Singapore, Chinese, English, Polish, and so on and so on. The catheter is spreading. Here I am in Moscow. I will show you the video. And in Moscow now they like the catheter. I was performing catheter foam sclerotherapy in the operation theater. There were 300 people in the auditorium. And here I'm in Brazil. And this is the video. So now I show you the video because later in the afternoon I will show you conversely the on-table procedure. If they can start with the video. This video is taken from Moscow, and it's a 9 or 10 minute video where I show something step by step. I was in the operation theater with anesthesiologists, with a lot of people around on me. I was a bit, you know, it was, yes, it's going. It was a bit too much, let's say, but they wanted to have it as a very big procedure, but okay. This is a kit, this is a possible introductory kit, okay. You see, that's a very similar, if not exactly the same like laser and radiofrequency. I think some of you perform laser and radiofrequency. Okay, Professor Popovich, of course. I don't know who else. Then you need to perform the transcutaneous cannulation. So I mapped the vein, okay, then you see the safena magna. Here it's about maybe 4 or 5 millimeter. It's around 4 or 5 millimeter. And I enter with the needle into the vein, and then I put the guide wire. This is a normal procedure to enter the vein transcutaneously. You can do it surgically if you like. Hook the vein out. That's another option. You take the vein with the hook out, and then you put the cutter. That's an option. Otherwise, you can do transcutaneously. I got the vein, and then my assistant is putting the guide wire inside, okay? And remove the needle, the guide wire is inside, and now we put the introductory and the sheath, I don't know. Koshur? I don't know.
We also say sheath.
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 Okay, the sheath is inside now, okay, the white part. And you remove the guide wire. I mean, that's the normal cannulation. So we have the sheath for some 15 centimeter here, and the external tube. There was some problems communicating with the nurses because I didn't know Russian, so the nurse was not washing properly. I was trying to tell, please wash, but that was not easy, okay. Then you can put your catheter. The catheter is centimeter, let's say, so you can see how long it is. You check first on the skin to see how long it should be, and it enters. Usually I put the catheter some 5 centimeters below the junction because I don't need to be so close to the junction as with laser, as foam invariably goes forward. You don't need to be exactly at the junction. It could be even wrong, let's say. So the catheter is entering up to the junction, and it will be placed about 5 centimeters below the junction. So it's a transcutaneous procedure, very, let's say, simple. Then we attach saline solution. So far, saline solution. And here is saline solution Finally, the nurse put saline solution because I was telling, please wash from here. Okay, saline, saline. What does it mean? That during myotumescence, she gives saline solution, which will be here and here. So all saphenous vein is filled with saline solution and nearly no blood. Then I start myotumescence, and tumescence should be as much as possible in the saphenous compartment. You see here, this is the saphenous fascia, and you try to stay exactly at the level of the needle must be very close to the catheter, and you completely squeeze the vein. Well, I'm using hand with the 50 milliliter syringe. You can use Klein pump. I know that someone uses pump. This is the sheath and stops here, and this is the catheter at the moment. But okay, so tumescence will be all along the saphenous compartment to squeeze the vein, thanks to you see how it progresses. But that's exactly the same as laser and radio frequency. In the meanwhile, the nurse should give some 1 milliliter of saline solution every 15-30 seconds, let's say, just to clear out the blood, okay? And I finish tumescence, I go to the groin, and all the saphenous compartment should be squeezed, and some more tumescence at the level of the junction, okay? This is something very simple that you probably know. In the meanwhile, I clear the saphenous vein completely of blood. Okay, I'm checking in transverse. This is the saphenous vein with the catheter. Okay, you cannot see well, but and it must be completely compressed, as you see. So there should be only the vein attached, let's say, stuck to the catheter. Once you check it, it's ready. It's 3 minutes, 5 minutes tumescence, and it's ready. 3-4 puncture. Because I was told by a few doctors, oh, but it is painful tumescence. Well, 3-4 puncture in the thigh, I don't think it's such a big issue. I prepare foam, you see here. I'm preparing foam, and in the meanwhile, removal of the blood here, giving saline, and giving saline from here. Completely 20 milliliter removal of the blood, ready, and I give my foam into the vein. I will show you how to make foam later. Ready to, here this is some phlebectomy, mini phlebectomy which was performed, okay? And now we are ready to give foam with the traditional Tessari method, and these are discarded syringes. We will discuss later during the live demonstration, because discarded syringes are the white ones, no silicone at all. You cannot use discarded syringes with a needle because it will be nearly impossible to use. They are very sticky after performing foam. With the catheter, with the cannula, no problem because it's in the vein, so you just push slowly, and we give as a standard, let's say, 1 milliliter of foam each 5 centimeter of vein. The thigh segment is around 8 milliliter because it's around 40 centimeter. Maybe in Serbia it's longer because you are taller than Italians. Could be 45 centimeters, the thigh, okay? So, retrieving the catheter in some 40 seconds, 1 minute, you fill completely your vein with foam while retrieving the catheter. The first milliliter of foam fills the catheter, and then you start to retrieve the catheter step by step. And the final image is just the tiny white hair. This is all live procedure. I mean, there is no cut. Unfortunately, it was not in Trendelenburg because it's not easy to organize everything. I prefer to do it in Trendelenburg so that it is even less bloody, let's say. So after the procedure, we check. I'm checking with the duplex, and you will see the tiny white hair. Here it is. That's the saphenous vein. And if you check for 20 minutes, it's exactly the same, for minimum of 10 to 20 minutes. Why? First, because of mechanical action of tumescent. Second, because of adrenaline, which keeps the vein into spasm. So there are, some little complications, I agree, but it's exactly what you do with laser and radio frequency. So why not to do with foam? You spend much less and you get the same results, very, very likely. You see how little it is, and it is dead, probably forever, let's say. I think we are at the end. We should be nearly at the end, okay.
How close to the
Can you stop the video and go to the next slide, sorry? Please.
how close to the saphenofemoral junction?
Yeah, we
You
stop
start with
5 centimeter. We prefer 5
5
centimeter below, first milliliter to fill the vein, to fill the catheter, and then you start to give
Similar
1
to glue.
milliliter, retrieving the catheter. Yeah.
similar to glue.
Yeah, similar to glue, yes, 5 centimeter above. So this is a live video to show you how we do it. So in conclusion, there should be another one? No, maybe I'm wrong. Okay. In conclusion, if you use catheter foam sclerotherapy with irrigation, with tumescent, you may treat larger veins. You may get better efficacy. You get also safety. But you need perisaphenous tumescence infiltration, ultrasound guided, and saphenous irrigation prior to foam entrance. And then you basically get the possibility to treat the vast majority of all patients who have varicose veins. Why do I show you this slide? George Fagan is the godfather of sclerotherapy, and he always talked about empty vein technique. Maybe you heard about that, empty vein technique. This is Bremen in Germany, 1999, a very young Attilio. George died 5 years later, probably, and he was talking to me. George was a legend, and he was telling Attilio, empty the vein, you get better outcomes. And he was putting bandages and bandages, no chance. You cannot empty the vein. And you can do it for 1 minute. So I was thinking, how can I empty the vein? Probably we have realized his dream, to empty the vein prior to foam entrance or to liquid entrance. That's why I want to dedicate my talk to him from this point of view. Okay, if you have any question on catheter foam sclerotherapy tumescence and irrigation, because then we move to compression. Any question on this procedure, which is innovative, but maybe interesting for those who want to improve? Yeah.
Which is your formula for tumescence anesthesia?
Well, my formula is based on mepivacaine. I prefer mepivacaine because I use only mepivacaine in my setting. I don't use lidocaine because it's too short, let's say. Mepivacaine, 45 minutes, 1 hour is okay. So mepivacaine, I use sodium bicarbonate to buffer the solution, and adrenaline and saline solution. This is what I combine. You can use lidocaine, but I would never use corticoids, because in Klein's solution, originally for liposuction, he included corticoid, which in my opinion is useless completely in this case. But also I think in laser and radio frequency it's a nonsense. Other questions? They are all hungry or tired. Okay. Okay, so we move ahead, and if there are no more questions. Okay. We talk about compression. If I cannot conclude with Stuart, we will finalize later after lunch, but I think I can make it. Why should we compress? And now Mehdi is happy because we speak about compression, not only sclerotherapy. First of all, we may optimize the result. Well, that's true, but we have not so much evidence that we optimize the results, okay? Surely, if we do not optimize completely the results, surely we reduce side effects. which means hematoma, pain, clot retention. We make some prevention of DVT, pulmonary embolism. We may reduce hyperpigmentation, phlebitis, edema, and so on and so on. This is something to summarize. What's the problem? The problem is that literature is a disaster, let's say. Literature on compression is a disaster because it's variable, different surgeons, different procedures, different regimes, different material, different patients. So it's not easy to get evidence. Everybody agrees that compression helps. Compression reduces side effects. That's it, stop, full stop. But how much, how to do it, so that's the issue. So if you perform surgery, as we perform, for example, phlebectomy for the tributaries, then you have a higher invasiveness procedure. If you perform laser or foam, you have a lower invasiveness procedure. Let's talk about laser. What's the evidence? Here we have an Italian group, Maletti and Lugli, using Struva 35, this is a study with Struva 35 in laser and eccentric compression, they got a much better pain resolution. So on pain, compression works for sure, not because of this study only, but for many other studies. When you look at this study from Maurins, Rabe, Ritz, and others from Latvia and Germany, you see that after 28 days, nothing special happens. So they like up to 7 days. If we talk about stripping now, not about laser, this meta-analysis of randomized controlled trials basically say that 4 weeks later, nothing changes if you use or don't use compression for 4 weeks. So probably the conclusion of this study is no benefits to long-term compression, but just for short-term compression, for example, 7 days. Let's talk about sclerotherapy. Here you have some more evidence, let's say, because Kern demonstrated that you get better clearance in spider veins, which is something we love. We want to clear the leg from spider veins. If you look class 1, in addition to 1 week of class 2, you get less bruising and pigmentation. But, for example, Thomaset demonstrated that it depends on the compliance of the patients. So, compression in sclerotherapy work. There is a problem, the French. Not because of the French. There is no French here? Okay. No, what's the problem? The French hate compression, we know. Okay, let's have a look at this study, which is always presented everywhere. Hamel Desnos demonstrated that 15 to 20 millimeter stocking for 3 weeks gives no compression, no benefit at all in ultrasound-guided foam sclerotherapy. And everybody said, you don't need compression after the foam sclerotherapy. Okay. Now, take a breath, Attilio. 15 to 20. How is the protocol? If you look at the article, they made 1 injection in the thigh to treat the saphenous vein. That's it. 5 milliliter injection. That's it. So we are not talking about foam sclerotherapy, tributaries, pigmentation, matting, whatever. We speak about 1 injection on the great saphenous vein and then 1 stocking. No benefit. Okay. 1 injection. But let's go here, 15 to 20 millimeter of mercury. Everybody knows that if you have a 15 or let's say 17 millimeter of mercury here, whatever you have, at the thigh, exactly where you made the injection, the compression is 5 millimeter. So basically, Hamel Desnos demonstrated that nothing is worse than nothing. We agree. We agree. Nothing is worse than nothing, or is equal to nothing. We agree. That's mathematics. So if you give a 5 millimeter compression in the thigh, and you want to say it doesn't work, it's incredible to me to have this study. Giovanni Mostri, Parch were crazy about this study. How can you say it doesn't work? Giving 5 millimeter of mercury in the thigh. when you need 100 millimeter of mercury to occlude the saphenous vein, or let's say 80, 70, okay? Not 5. So, full stop, it has no meaning. This is for bandages, then 10. Well, they demonstrated that was probably a high-risk study of British, I don't remember. But again, the majority of the experts and of literature reports are in favor of compression, for example, in these guidelines, when you perform sclerotherapy. Somehow, you can use bandaging or you can use stocking. And unfortunately, the level was grade 2C, so it's not high at all. But we would recommend a minimum of 23 to 32 millimeter of mercury if you treat the saphenous vein especially, but also for telangiectasia, as you read here, because there is some evidence that helps for telangiectasia. Which is the problem? The problem is that the British are very tough, very strong, and they perform a lot of systematic review. And they say, we don't know. They say, we don't know, according to literature, because there is currently little quality evidence upon which to base any recommendation, and so on and so on and so on. The problem is that all the studies have different methods, different surgeons, different procedures. So it was really impossible to draw any sound conclusion. But everybody would agree that compression helps at the end of the day. This is what we know. And these experts, trying to summarize all this literature, concluded that at least for 1 week you should compress after any intervention on saphenous veins, at least for 1 week. And that's Eber Arabe, Ugo Parch, Giovanni Mosti, and so on and so on. So this is something to keep in mind, at least for 1 week. So in summary, the main benefit of post-interventional compression, if saphenous vein is treated, is limited at least for 1 week, let's say. When you treat telangiectasia and reticular varices, you should compress for a longer period. This is what we get from literature. Unfortunately, we lack uniform data, and that's why we are trying to understand. And again, if you use 18 millimeter stocking, as in many studies, we need proper compression before drawing any sound conclusion. So this was the second presentation. Okay, thank you. And now questions. Thank you. And now questions, because then we have the last presentation should be about Struve, if I recall well. And complications also. Wow, we have 2 presentations. Okay.
Let's continue.
No questions? Okay, so if we have no questions, we move to the next one. Okay, that's the Struve stocking, staying on the, let's say, on the compression issue. So basically, we wanted to understand if you need higher compression, lower compression, at least for one single treatment, which was, in our case, catheter foam sclerotherapy for saphenous vein and phlebectomy for the tributaries. So a mix of sclerotherapy and surgery, a kind of bastard, inglorious bastard procedure. Okay? Richard, remember, inglorious bastard procedure. Inglorious bastard, you remember? Tarantino. Okay. So anyway, this inglorious bastard procedure, which is glorious bastard procedure, was checked as to compression. Okay? Why we should compress, we told before. Okay, we go ahead. The evidence from literature was not so clear, so we wanted to check, because that's sclerotherapy, and that's the guidelines which I showed you before. Sorry, that was shown before in this case. Let's move. Okay. In this study, the Germans demonstrated that 23 to 32 millimeter of mercury stocking at the ankle we talked gave, and that was Mediven, that gave faster resolution of clinical and ultrasound verifying edema and pain especially, and let's say discomfort in the earlier period. But when, let's say, when they used in a longer post-surgical period compared to a lighter stocking, there were no differences, okay? So we wanted to check better. We performed a randomized control study where Struva 23 was compared to Struva 35 after saphenous catheter foam sclerotherapy and phlebectomy. This is the study design. At day 0, there was the randomization at the enrollment, and Group A had a 23 millimeter stocking, Group B had a 35, and we performed a clinical examination, duplex examination, bioimpedance, I will tell you in a second something about bioimpedance, and the vein procedure was done. At day 3, we called the patient on the phone. How are you? What's your feeling? All the issues from the visual analog score telephone interview. Day 7, removal of a Struva, clinical examination, bioimpedance again, patient-reported outcomes. And at day 40, again, clinical and duplex examination, bioimpedance, patient-reported outcome. But at the end of the first 7 days, they removed Struva 23 and Struva 35, and they have worn the Medivan class 1, so up to 21 millimeter of mercury. Okay? This is the study. And that's the Struva, which we put on the stocking, on the limb after procedure. And the patient, in all cases, went back home in 1 hour after the procedure. Bioimpedance, I want to talk a second about bioimpedance. This is important. Because bioimpedance is one of the very few, if not the only possibility we have to check quantitatively and not qualitatively about edema and tissue. Bioimpedance, probably you know it, okay, is based on the passage of electricity, for example, in the body, or, this is the spectroscopy, in the limb. So you may check how much fluid is in the limb. The higher the fluid, the lower the resistance, because electricity goes fast in the fluid, slow in the tissue, in the bone or whatever, okay? So the higher the fluid, the lower the resistance. And then bioimpedance can study also tissue a little bit through the cellular membranes, because again, the electricity at a certain frequency goes only through the cellular membranes. And so you know how the tissues go, okay? So you can study tissues and edema through bioimpedance. The two groups were very similar, and there were no statistically significant difference, so they were comparable groups, Group A and Group B. Let's start with the symptoms: pain, heaviness, ambulation, and stocking stability were better scored in Struva 35 group. If you look at here, now I have not the possibility to show, but if you look at pain, for example, you see let's say the gray group is 23, the white group is Struva 35, okay? Struva 35 was a little bit better at 3 days, at 7 days, and at 40 days, even 0 in the Struva 35 in this case. So pain was really probably the best score symptoms for Struva 35. The rest was quite similar, a little bit better ambulation, you see, for Struva 35, which is more stable. It's a waist attachment. We use the waist attachment, okay, not the silicone band, how do you call it, okay? So so Struva 35 was a little bit more stable, and so that means you can walk a little bit better without slippery and so on and so on. So these are the symptoms. Similar, especially at 40 days, they tend to be similar, but the first 3 and 7 days, a little bit in favor of Struva 35. And these are the symptoms, all score, but okay, I don't want to go too much into details and so on and so on. If we look at skin findings, for example, such as ecchymosis, hematomas, dermopodermitis, skin healing, skin blister, pigmentation, basically quite similar again. The only difference was skin healing, you see, was statistically better, especially at 7 days. At 40 days, not such a huge difference. So let's say, quite similar in terms of skin findings. When we look at bioimpedance, to make things simple, okay, at 7 days and at 40 days, they were quite similar, but incredibly, at 7 days, everybody said, oh, after operation you have edema. No, at 7 days they had less edema than before the operation because of Struva, because of the operation we improved a little bit the hemodynamics. More than this, you see, reactance, and reactance is the component of the vector impedance for tissue, was better for Struva 35, and also the index between the two limbs was a little bit improved in Struva 35. But resistance which was on edema, was quite similar. And Ugo Parch was very happy about that, because Ugo Parch and Giovanni Mosti demonstrated that even 20 millimeter of mercury could be good for edema. Even 20 millimeter. Okay? So generally speaking, bioimpedance slightly in favor of 35. Slightly in favor. Okay? Bioimpedance. So the conclusion of the study: compression therapy with a pressure of 23 to 35, or 23 or 35 millimeter mercury was safe and well tolerated in the vast majority of the cases. The beneficial effect on edema and tissue was slightly in favor of 35, Struva 35, especially as to skin healing, especially to ambulation stability. But as you see, both talkings were quite similar for many, many things. If you have a larger limb, if you have a worse procedure, big varices, I would prefer, of course, Struva 35, which is my favorite stocking in the majority of the cases. If you have a slim limb, slim patient, and not a big procedure, Struva 23 could be another good option, let's say. Depends, of course, if you perform a stripping with big varices, then Struva 35. But if you perform laser with the normal varices, probably 23 or 35 could be similar. Again, 35 can be better for pain. Again, let's remember pain. Okay, that's all about this study.